Welcome to the Rehab and Performance Lab, the MedBridge podcast where we dive into the world of orthopedics and sports. We're here to unpack the big topics, offering you practical insights and valuable tips from some of the most inspiring professionals in our field. Don't forget to visit medbridge.com to get your continuing education credit for this episode, plus access bonus resources. Hey everyone, welcome to the podcast. I'm Phil Plisky, your host. I'm a professor and author at philplisky.com and a performance systems consultant in professional sports. Being a physical therapist and athletic trainer and strength and conditioning coach, I like to come at this from multiple perspectives. We want to bring you the latest evidence, but more importantly, we want to make you be able to use practical solutions in your clinical practice. I'm looking forward to our topic today. Is surgery really necessary for musculoskeletal conditions? I'm joined by Dr. Alexis Wright, professor and program director for the Doctor of Physical Therapy program at Tufts University, Boston. Welcome to the podcast, Lexie.
Yeah, thank you, Phil. Thanks for having me.
Fantastic. So glad you're here. Could you tell me a little bit about your professional background?
I sure can. Maybe I don't want to say my age, but where do you want me to start? I did my undergrad at the University of Illinois in kinesiology, and then knew kind of right away I wanted to be a physical therapist, and did my DPT at Duke University. And kind of early upon graduation, I went right into orthopedics, outpatient orthopedics, and got the itch to get back into kind of academia. Wanted to do some research and clinical practice and do some teaching, as I always enjoyed the students. So I did my PhD at the University of Otago in New Zealand, which was a really awesome experience.
Oh my gosh, that's a bucket list for me.
Oh yeah, absolutely. Probably one of my best life decisions. I have the island of New Zealand tattooed on my foot.
I might, I just have my mere DSC. I may have to just go back and get my PhD now just for that reason to go
there. You go. Yeah, and after that, I did a manual therapy fellowship at University of Illinois, Chicago, and then took my first job in academia after that at High Point University in North Carolina, where I served for 10 years and worked my way up to associate program director and director of curriculum there, and joined Tufts in 2020 as their director of curriculum, and was appointed program director in January of 2023. And that's where I am now.
That's fantastic. Awesome. Well, tons of experience. I'm so glad you get to share that with our audience. So tell us a little bit more about how this passion for surgical management versus conservative management of musculoskeletal conditions kind of started and it has evolved over time.
Yeah. So interestingly, my PhD project way back in the day was actually looking at the effects of physiotherapy, as they say in New Zealand, versus surgery for patients with hip osteoarthritis. So that's probably where it started. And I think, kind of as an early clinician, and admittedly so, when I was first in the outpatient ortho clinic, I was seeing a lot of patients post-operatively, and I just kind of kept wondering, could this have been managed conservatively, right? And I think that's just where the itch came from. Is I was really interested in it continues to be less research really comparing surgery versus conservative management. And there's a whole lot more to do. And so I just never want to downplay the effect that we can have as physical therapists. And so it just excites me to kind of talk about it. And there's some research, some more recent research coming out that actually suggests that, hey, wait a minute, for some of these historically, populations that have had surgery, actually we're finding out now that conservative management might be equally, if not more effective. So it's a pretty cool time in physical therapy, I think.
That's awesome. I was on a consulting call this morning and talking about curiosity and really how that's actually one of the most important factors in being great in whatever you do. So I love that you've had that curiosity from the beginning. But tell me why this is important to discuss. We're talking about surgery. We're not going to do surgery. We're not licensed to do surgery as athletic trainers or physical therapists or strength coaches. Why is this important to discuss this research?
Again, I think historically there have been populations where it just almost became automatic. It's like, nope, that patient needs surgery. And I think, again, I really hope that we can continue to advocate for the services that physical therapists can provide. And I mean good physical therapy. And I say good physical therapy because I think it can be really difficult and challenging when you're a kind of a clinician scientist and you're trying to read the literature And the studies come out, and sometimes they'll quite often say, right, physical therapy had no effect, or in surgery had these massive effects. And yet it can be difficult when you're kind of digging into the literature to see, well, what kind of physical therapy was being
Right.
offered.
Was this
And I hate,
was this ultrasound in
right.
a hot pack, or was that,
Yeah.
was this a modality, or what, a lot of times in the medical literature,
Mhm.
physical therapy is
Right.
synonymous with modalities.
Right, which I utilize almost none. And
Right.
so and it's challenging, right? Because research is challenging. And so, there's so many restraints on, well, okay, if it's going to be in a research study, it has to be very, very prescriptive because it has to be repeatable and replicable. And yet that's not how we treat our patients.
Right.
Right. Typically, if you're providing, right, we hope as a good physical therapist, you're individualizing your treatment to what your patient needs. And you can't do that in a research study. So when you try to just say, well, everyone's going to get these 5 things, I'm not surprised that quite often historically it has said physical therapy had little to no effect. So again, I
We
think,
haven't matched the treatment, to the
right,
patient.
right, exactly. But it's like I said, it's interesting because there are, at least now, finally, some studies that are showing that when you compare conservative management to surgery, that these patients are having that both of those treatments are providing kind of equal effect. And I
So
think it's
let's
shocking
can
to
you dive
people.
into those studies? Let's talk through some examples of those studies.
Sure. I mean, I think the first ones that kind of came out that kind of shocked, uh, the medical world was in rotator cuff tears. And some of that stuff came out probably as early as like 2005 because again, right, it's like rotator cuff tear, got to have surgery, shoulder
Yeah, there's no other
impingement,
way.
right?
It's
Yeah,
broken, you gotta fix it.
absolutely, right? Shoulder impingement, it's a biomechanical thing. The tendon's getting wrapped underneath, the grade 3 acromion process. Got to go in there and debride and shave off the acromion so you're not getting impingement. And yet, what they have found, and even in kind of 2, 3, 5 year follow ups, is about 75% of those patients would have been just as good having just had conservative management, right? And so that brings up a whole plethora of things, which is, I can go on a lot of tangents. The first one
Let's
is,
hit it. This is
right,
hey, we
yeah,
get to have a good conversation here, and people get to listen in, so
right.
let's go with it.
Well, I mean, I think the first one is, again, I think surgeons typically will have large research teams, so it can become, and they're funded quite often can be funded by medical device companies. And I'm not throwing that under the bus, but it can become easier to get research published and lots of it. And so those research studies typically come out first. And again, I think as a consumer of the literature, you have to understand what you're trying to look for. So a majority of those studies, and it's something like 85% of those studies, don't ever have a comparison group. So,
Mhm.
yes, we know that surgery helps. We know it
Right.
helps. We know it decreases pain levels, but they're not ever comparing it to conservative management. And so, what ends up happening is, there's this plethora of research that comes out. It's not being compared to anything else. It's showing great effect sizes. So, everyone adopts it. So, everyone needs surgery. And then we come to find out later that when research actually does get published 10, 15 years later, where they've actually compared surgery to conservative management, that actually they have equal effect sizes. So then all of a sudden it's like, oh, wait a minute, we didn't have to have this 600% increase in the number of surgeries that were being performed.
Are there specific examples of that? You talked about rotator cuff tear. Are
Right.
there others in other parts of the body?
So there are. So I'm given kind of just my background and my PhD, having sort of hip osteoarthritis, I then kind of moved towards this research line of looking at patients with femoroacetabular impingement syndrome. And I was looking at that because, again, I was thinking, okay, well, if we can catch those patients earlier, because we know those patients quite often will proceed to having hip osteoarthritis. So I was looking at kind of trying to catch those patients earlier. So that same thing happened with femoroacetabular impingement syndrome. And we saw this, and it's literally in the literature. There was, in a 10-year span, the number of hip arthroscopy surgeries being performed because of FAI syndrome increased 600% because a bunch of studies came out. And right, we know, yes, patients got better, pain went down. They went in, they thought the cam and the pincer morphology was the primary, contributor. So I'd go in, they'd shave those off, patients feel better, they get out. But again, same thing. So it literally kind of replicated what had happened in the shoulder. But historically, we know shoulder studies tend to come out first and then hip studies because I don't know, the hip seems less sexy to people, I guess.
Right.
And so,
Like, a lot more surgeons do shoulder surgeries than do hip
right.
surgeries.
Yeah. And so it literally almost repeated what had happened in the shoulder. All this research comes out, surgery is helpful, the number of surgeries go up. And I will say that, you know, for FAI syndrome, there are still only, that I'm aware of, maybe 3 studies that are now comparing hip arthroscopy to conservative management. And it's trending the same way, right? Which is both groups. So I did a really small pilot study back in, gosh, I don't know, 2016, 2017. It was a pilot study. And everyone got better with physical therapy. And then now there's some larger research studies that are suggesting that, you know, it's mixed. One study says that surgery provides better outcomes. All the studies say if you have surgery or if you have physical therapy, that patients are getting better. And then it's mixed. At 2 years, one study says there's no difference between groups. There's a study at 1 year follow up that says, well, the surgical group does better. Interestingly, written by a surgeon, funded by
The
right,
device company, right?
a
Right.
medical device company. And so there's already mixed evidence and there's only 2 to 3 studies. So I have a sneaking suspicion that over time we may find this, and the longest outcome they're looking at right now is 2 years. So what happens at 5 years? And what happens when we have 5 to 10 studies? Are we going to see the same thing where it's like actually conservative versus surgery, no difference between groups?
Or is there maybe even a difference in the long-term outcome where one horse starts the race really fast
Right.
and then the other, takes over afterwards.
Mhm.
We really don't know that. We don't know whether, I mean, we might, there could be that kind of U-shaped phenomena where, surgery starts out less and actually at 5 years has better outcomes than even conservative treatment, but we just don't even know.
No, you're absolutely right. And I think regardless, physical therapy plays an important role in either of those situations because I would also, you know, place money on the patients who underwent surgery. If they do end up having better outcomes, it's because they had better post-op PT.
Well, and that's just it, so we
Right.
see this in the elbow literature with Tommy John surgery. So that's something I work a lot with in baseball is I have to combat youth who want to get, ulnar collateral ligament reconstruction because players that do get back actually throw a little bit faster. Well, do they throw a little bit faster because they suddenly have a rubber band ligament in there? No, they go because they shut down for an extended period of time and went through very rigorous rehabilitation that focused on fundamentals, that focused on movement, that focused on strengthening the right muscles at the right time.
Yep.
And therefore, they actually perform better. But it was it the surgery or was it, the rehabilitation? Well, maybe the
Right.
surgery provided the stability that was necessary, but it was the rehabilitation that made him throw faster.
Right. Well,
So
absolutely. Yep.
so if that's the case, so if we're, somewhat mixed in the literature on different topics, how do we deal with that from a rehabilitation perspective? Like when we go to apply this in a clinical setting,
Yeah.
what does that look like? How does this impact what we do?
So, I think one of the biggest things in is the topic about patient education. So, as you know, right, patient expectations plays a huge factor in how they're going to respond to whatever treatment they're being prescribed. Right? So if a patient is scared of surgery, they tend to have a less favorable response. If a patient is already convinced that nope, I'm seeing this on an x-ray, I'm seeing this, I've been told I have, and I'm just gonna, the historical one is like, nope, I'm told I have a blown disc, right?
Right.
And the only thing that's going to fix it is surgery. Your physical therapy is not going to be effective. There's tons and tons of literature that talks about patient expectations and patient response to treatment. So I wish I had just a like, well, this is exactly what we're going to do, and we're going to we're going to do it this way. But I think patient education is probably one of the key pieces here, and we as physical therapists need to have that background and be able to educate our patients enough on these studies that I'm talking about that, hey, did you know that actually, if you're looking at 2-year outcomes, if you're looking at 5-year outcomes, that actually your response is exactly the same and there's fewer risks with physical therapy compared to surgery. Um, so I think again, patient education is a huge piece, and again a lot into that. I spoke to oh my radiograph shows this.
Well,
Well,
that's what I was just thinking. So are
right,
we not just going right down that same line? Because, if I'm going to put myself in a patient's perspective, try to, I think that's what we always need to do is try to
sure.
sit in the other person's, shoes, so to speak. And I'm sitting there and I'm like, okay, I have a torn meniscus. Okay, first of all, that just sounds awful, right?
Right.
I mean, I don't even know what a meniscus is, but it's torn.
Right.
I mean, it's kind
Yeah.
of like mechanic walking out and saying,
Yeah.
you've got a clogged Spetzer valve, like, oh my gosh, well, I can't imagine. It has to be unclogged in order for this to operate, right? So I've got a torn meniscus. I'm sitting here, I've got a torn meniscus.
Hmm.
How do you talk to me about that?
Yep. So meniscus is a really big one that has actually had a lot of literature lately. And just so if I'm just sharing my personal opinion based on the literature, I would first of all, if you have something that's a degenerative meniscus, and I know, given our audience, we're going to know the difference between kind of an acute versus a degenerative older age.
Well, hey, let's dive into that. Well, let's say
Right.
how would you characterize that difference?
Yeah. So obviously, right, degenerative. I hate to say it, right? I'm what 43, so I'm probably getting there. Right. So probably over about the age of 45. Honestly, there almost everybody, if we took an image, probably has some type of degenerative meniscus. It's a normal part of aging, and I think that's the education, which is to help patients understand. Hey, no offense, but sometimes getting older sucks. I wouldn't say it that way,
Right.
but right, like there are normal changes that happen over time as we age. So a meniscus that is thinning because we're aging is normal. And so again, historically, the it has been, well, we're going to do a meniscectomy, right? It's degenerating. There's pieces we need to go in there. We need to cut it out. There's enough literature now that if I see someone over the age of 45 with a diagnosed with kind of a degenerative meniscus, I'm not recommending surgery.
So
There.
how do you have that conversation? Because they've
Yep.
come into
Yeah.
you,
Right.
they come in with this
Mhm.
MRI, and
Yeah.
I always use the analogy, if someone if we think of an X-ray or an MRI as a picture, it would
Yep.
be like someone taking a picture of my face and saying, you know what we found some lines right next to your eyes and right around your mouth. Those lines aren't there when you're young.
Right.
It'd be like,
Yeah.
well, it's not pathological. It's just you'd be like, of course, I'm a little older.
Yep.
So,
Yeah.
how do you talk about that though? How do you get them from, I've seen the surgeon.
Yep.
They said could do surgery or physical therapy.
Right.
I'm here to give it one visit because my
Yeah.
insurance company said I had to.
Right.
How do you deal with that?
Yep. So again, it's educating the patient about kind of the normal process of aging. So literally sometimes an example I'll use is yes, like, yep, I see that. I can see that's showing up on your image. Were you also told that if I put 100 people in the room, we wouldn't be able to differentiate between those who showed those types of findings and those didn't, and those who had symptoms and those who didn't. So even though it's showing up on your image, that doesn't necessarily match to your symptoms. And there's plenty of research to show that now, that a kind of a morphological change doesn't necessarily match symptoms. And so then I'll try to talk to the patients about, you're right, I'm not gonna fix the image, but I can't but there are a lot of things that we can do as physical therapists to treat your symptoms. And then I would talk to them about, so yes, I saw that was on your image, but have you also been educated on the fact that in patients, again, over the age of 45, there's multiple studies now that say it again at 2 and actually that 9 out of 10 patients who don't have surgery do just fine. have the same, right? It's, in fact, those who have surgery, it used to be the theory that you did the surgery to avoid developing knee osteoarthritis.
Right.
There's actually evidence now that says the patients who have the meniscectomies, they're at increased risk for developing knee osteoarthritis, which honestly makes sense because even though it's degenerating and there's still something there. And so
Absolutely.
if you remove another aspect of your knee joint that's preventing joint loads or helping dissipate joint loads, and you remove that entirely, it makes sense that you're going to be more likely to
Right.
develop
So yeah, some
knee
some cartilage is
osteoarthritis.
better than no cartilage.
Right. Right. So
Absolutely.
I
So
think it's that. Making sure they have all the information. There's a lot about like shared decision making. It doesn't mean I'm necessarily going to convince someone, but patients need to have all the information and not just bits and pieces of it before they make a decision.
I do a lot of education of that with our entry level students on job selection and going about the process and professional development, that they need to get the opinion of multiple people in this process. I have a strong opinion one way. Their parents are going to have a different opinion there, and you have to consider the source, what the person's bias is. Right. So, you and I have a bias as rehabilitation
Yep.
providers, and that's a bias. And we've got to recognize that. The surgeon has a bias as an orthopedic surgeon, and you just got to recognize it.
Absolutely.
Doesn't mean he's bad or
No.
she's bad. It's just that's their solution to the problem.
Yep.
Now, one of the things that I've gotten away with or gotten away from is I abhor the answer. It depends. Okay, like it is the number one thing that's given in physical therapy and athletic training school, and I just really don't
Yeah.
like it. So now what I say is context matters.
Mhm.
Okay. So if you're asking me a question, I'm not going to respond with it depends. I'm going to respond with let's develop some context that would help inform our decision in that process.
Sure.
So let's put some context around, you say, all right, in general, 45 years old, gradual onset. Are they, I'm going to lean toward, conservative approach. What would be the other end of the guardrail on that where you would say, here are the factors that I would say that person needs a surgery
Yep.
at this point in time?
Yeah. So, I mean, for one, I think we have to give physical therapy a fair chance,
Okay.
right? So I think that you kind of spoke to it. Like I'm going to come for one visit because of insurance, and again, that's a whole other thing about whether insurance is covering it. But at minimum, let's give physical therapy a 3-month trial because if it's exercise prescription, we know you're not going to have an effect in 2 to 3 visits. So again, if that's what we're comparing it to, then correct, physical therapy is not going to be effective. And let's see, how they're responding, and then let the patient decide. Well, actually, wow, I'm really improving. So maybe I don't need it after all. And if I keep doing this for a little bit longer, then maybe. If they're not improving and they're still in a 7 out of 10 pain, and we've given it a really good shot at physical therapy, right, and the patient's being compliant, then yeah, I mean, right, they come to see us because they're in pain. So I'm not just going to be like, oh no, like, well, then I'm never recommending it. Um, I mean, admittedly, so like I've had a hip replacement. So I've had surgery. I'm here talking about not having surgery.
Right.
But I did it. I mean, I think I know how to rehab myself, and I couldn't, it would not respond. And so, right, so I elected to have the surgery, and it was successful. I just think we need to flip the paradigm where, and I know we are moving towards this, but it has to be physical therapy first, surgery second, not surgery first as the first line of treatment. I think
Absolutely. Yeah.
there's enough literature now and enough of these kind of pathologies, low back pain, shoulder pain, cervical spine, SIJ, all these, and there was just a research study in JOSPT, all of them, that physical therapy is equally effective to surgery. So it should be PT first.
Right.
Um, yeah, and I guess I just can't say that
Can't say
enough.
that enough. Well, let me put it on a little more controversial subject.
Sure.
I like to dive in to the areas that maybe don't have the clearest answer.
Yeah.
There's a very strong push in the literature for non-operative management of ACL tears. Okay. And
Yes.
so if we think about this now, and I would like to give it to maybe the UCL analogy,
Mhm.
the Tommy John surgery. There is something about restoring the
Yeah.
mechanical properties and the proprioceptive properties of that UCL that if you have a torn UCL, your likelihood of returning to throwing goes way down just because mechanically the joint just opens up too much,
Right.
with that said. Now there's this big push on, hey, we probably can treat ACLs without surgery. What do you think about that? And is that potentially different than what we're talking about with the meniscus or femoral acetabular impingement?
Didn't you say you hate it depends? But
I
I'm gonna
do. I do.
no,
How about you
it
give me some
it
context
does
instead?
it does it does depend. Um, so you're right, and that is definitely that's new on the horizon because that ACL, right? It's never been considered that if you had a full blown torn ACL that you wouldn't have surgery. So again, what the literature would suggest is if you're a highly competitive athlete in a cutting sport and you have a full blown torn ACL, the evidence would still suggest that that patient probably needs to undergo a surgical repair.
Mhm.
Okay. So again, so quote, it depends, right? If that person's wanting to get back, we can argue about the timelines, but again, if that person is a high level competitive athlete in a cutting sport, then they're probably still going to undergo surgery. Because if they try to continue to play, they actually put themselves at increased risk for kind of secondary injuries. Now, for the other group, right? Because let's be honest, how many highly competitive, athletes are we talking about? Yes, in maybe the highly competitive in high school, but then once you get into college and professional sports, we're talking about a real small percentage of the overall world global population, right?
Sure.
So if we're talking about our, quote weekend warrior or recreational athlete, or even what I think they'll kind of refer to as like level two athletes. Level two athletes necessarily, when I'm saying that is like cyclists, swimmers, runners. And again, because they're functioning primarily in a single forward plane versus a cutting sport and a dynamic movement, those patients potentially don't need surgery. And what they're suggesting again is that the outcomes from having a repair versus just conservative management over time is the same. And theoretically, if you're that type of athlete in cycling, running, swimming, you actually might actually have better. Well, you definitely would get back to your sport sooner than having undergone an ACL repair, and you might get back to higher level function definitely faster. So it's again, it is mixed. It's just that it shouldn't for everyone. The first treatment option should be that everyone with an ACL tear has to have surgery. There's
Right.
actually some evidence now that says actually some of you maybe don't need it.
One of the things on that, and we talked about this in a previous episode with Dr. Matzel on ACL return to sport timelines and things like that, and we brought up the concept of the ACL not being a mechanical restraint as much as it is a proprioceptive organ within the body. And if I look at things that maybe surgeries that have these equal outcomes, so if we think of, femoral acetabular impingement, meniscus, maybe rotator cuff repair to a lesser degree, these are not highly vascularized, which vascularization, kind of coincides with neurological intervention or innervation and things like that. So maybe the structures that are avascular might not have as big an impact of whether you have surgery or
Mhm.
rehabilitate it conservatively. But if the ACL needs to function in the future as a strong proprioceptor for you,
Right.
maybe the discussion should be around proprioception rather than stability. What do you think about that?
Yeah, I mean, I don't disagree. I probably haven't necessarily thought about it that way, but again, I think you're not wrong. And what they'll say is and again, stability versus proprioception is that when you do have the repair, it does restore some stability to the
Hmm.
joint, and
Sure.
versus those
Oh
who
yeah,
don't,
absolutely.
versus those who don't, they're
Yeah.
definitely going to have more laxity, right, as we go and
Correct.
test them.
Absolutely. Absolutely.
Um, but yeah, I mean,
Because we can teach you to walk
right,
without your ACL,
right,
which means the ACL is not the only stabilizer of the knee.
correct,
We're teaching compensation, right? And the
right,
body is masterful at
yep,
compensation. That's actually probably what we do in rehabilitation is
sure,
either teach compensation or remove compensation. Like we probably just summed up rehabilitation, whether it's neurological or musculoskeletal.
right,
And so you can't get away from the mechanical aspect of it, but if you can treat it non-operatively, that says we've taught a compensation, and maybe our decision is that compensation going to be okay for the person's proprioceptive demands?
yeah, yeah. When I'm teaching students about like you have a kind of primary line of defense for stabilization and a secondary line, right? So we have primary stabilizers, which is our like bony anatomy and our ligamentous structures, which includes the ACL, right?
Right.
And then when those fail, or you're talking about like ankle sprains, right? So when those tear or fail, then you become more reliant on your secondary stabilizers, which is all your muscles that are surrounding that tissue, to your point, which is why you see in the ankle literature as well as ACL, which is all work on proprioception becomes the most effective rehab,
Right.
right?
And that's what we do post-operatively as well.
Correct. Right.
And restore that. So this is a great discussion, and I love the idea that when we put a lot of context to this, now we are educating our patients to make the best decision that they can,
Right.
and we've got to be careful to not put our values on the person. That we say we're rehab providers.
Right.
You kind of said it yourself. Like I would never have surgery except that I did.
Yeah.
Um,
Right. Right.
but we value exercise and exercise intervention to heal the body and things like that. But ultimately, though, we have to work with that patient. We have to say, hey, here's the information.
Right.
You know, given two choices that are equal, maybe
Right.
here you go. And what are the downsides of waiting
Sure.
and giving rehabilitation a chance versus just go ahead and do the surgery. So I think applying those pros and cons.
Right.
If I'm a worker who needs to get back to work, and I'm going to try rehab for 3 weeks on an active meniscal tear that occasionally catches and locks. And you and I are both going, well, that's kind of a maybe.
Right.
I don't know. That's not the 60-year-old whose knee is
Right.
grinding type of thing. That's an active
Yeah.
meniscus. It'd be like, hey, here's the downside
Yep.
of waiting 12 weeks is now you haven't been able to work for
Right.
12
Right.
weeks, and then you need surgery,
Yep.
and so
Yep.
that is the context that really matters, isn't it?
Yes. No, for sure. And I say that when every time I see a patient, I even will upfront say, look, I know I'm biased,
Yeah.
right? You're getting a perspective from someone who's a physical therapist who treats conservatively. But again, it's back to that exactly what you said. It's back to that piece of, but here's all the information, right? And and also like I think again, this just circling back to what I said about good physical therapy, right? We have to have patient buy-in, and if we're gonna, and I use the joke. It suggests that I hate like the clamshell exercise, which I don't when appropriate.
Right.
But right, if all we're going to do is give this person like clamshells and single leg plane exercises, that's not good physical therapy, right? So the we have to do a better job of advocating for our profession by providing patients, by matching them to the right treatment options and giving them a true taste of what good physical therapy can be. And unfortunately, right, I think the healthcare systems, sets us up with the whole reimbursement thing is that, there's tons of burnout in physical therapists now.
Mhm.
They're just right in I hate in it. It's a shame because if I'm seeing 16 to 20 patients a day, I'm exhausted, right? The
Yeah.
best I can do in 30 minutes for that patient is like, what can
Is
I just
is
think
the
of?
is just the standard.
Right. And so then, and then it's not effective because they needed something different. And we're, as physical therapists, just exhausted, right? So if I tried to give individualized care to everybody, I'd run out of time. And then right. So it's a problem. But I think, yeah, we can have such a huge influence when prescribing exercises the way in which we know how to do it that really match our patients.
See, that patient matching is a huge concept, and matching with very specific exercises, very specific manual therapy techniques to very specific impairments is huge. I always give the example of saying, well, do plyometrics prevent or reduce the rate of ACL tears? And from the research perspective, the answer is yes, about 50%.
Right.
We tend to forget about the other 50% that it doesn't work
Right.
for,
Right.
but at least we got 50%,
Right.
right? But I always think about it as if I don't identify that person has an ankle dorsiflexion restriction, I can do all the plyometrics I want, and they will have an abnormal mechanical loading
Yep.
of their lower extremity that will guaranteed to predispose them to an increased injury risk. And if I don't have a systematic approach to be able to say, in all my patients, I'm going to identify these risk factors and these potential biomechanical factors that will, affect things. That's where we go back where we started this episode is good physical therapy, high quality rehabilitation,
Right.
high quality athletic training services,
Yep.
not you got a sheet of paper that had 4 exercises on it.
Right.
That's my knee program.
Right. That all tend to be single plane exercises when we function in a three-dimensional world.
Right.
It's not
Absolutely.
it's not gonna work,
Absolutely.
right? And then our
Absolutely.
re-injury rates go up and we wonder why. Well,
Why
because they
why is
weren't
that?
given they weren't given good rehab. So,
Absolutely. So let's talk maximum impact. Let's drive this home. What would you say? What would your actionable takeaway points be for the rehabilitation and performance professionals listening to this podcast?
yeah, I mean, I think we come right back to the same thing, Phil, which is patient education. Just make sure that we're giving patients all of the information. They're gonna come into you, they may have already seen the surgeon, they may have an image, they may already have a preconceived notion that, like, I saw the image, this is what it is. I have to have surgery because it's going to fix this. And so, again, educating them that sometimes image doesn't match symptoms, and it has to be more than just that because patients aren't going to understand that. So, being able to have a conversation about, just because it's showing there, what's the natural progression? How many people would that show up in who don't have any symptoms? Right. And then talking to them about the other side. So, yes, you probably saw your orthopedic surgeon. They're telling you this percentage of patients who have this, do this well. Okay. So, let me tell you from this side of things. Yes, with physical therapy, there are symptoms that we can treat. I'm not going to be removing your meniscus, but doesn't necessarily match your symptoms. So we can try this trial of physical therapy. And there are research studies to show that physical therapy in the long term is equally as effective as the surgical management with less risks. So if you would allow me to do so, let's give physical therapy a real shot, right? Which might be something like, at least 12 visits ish. And if you're no better by then we'll revisit this conversation, right? And then we'll talk about some other treatment options. And during that, those 12 sessions, giving that patient the best that we've got so that they have a real shot. So,
That's awesome. And so, yeah, so we're gonna in that we're gonna provide some high quality rehab. That's
right.
probably not a modalities based rehab or a if I always say that if you are giving your exercises and manual therapy based on a diagnosis, I can almost guarantee that you're not doing high quality rehab. What do you think of that?
Absolutely, man. So we teach her. My the students in the classroom. I don't even necessarily care that they come up with the diagnosis, but they have to match the treatment to the impairments that they found during the exam.
Absolutely.
Right. So
Absolutely. That's for sure. Well, so as we wrap up here, one of my favorite questions to ask is if you had to go back in time and, visit your early career self, what advice would you give yourself?
Yeah, I don't know. I think early career, um, I think well, again, this is back in the day, but I think there were still the idea that like there's the doctors, the physicians, right? And then there's the physical therapists. And I think um even though at the time we were, still considered direct providers, it didn't necessarily feel that way. So I think
Hmm.
again, for me, at least with regards to kind of this topic is, at least being willing to maybe have the conversations with the surgeons themselves too, and just to talk and try to have an understanding, I think, from both perspectives. um, and again, I think early in my career I was probably in one of those clinics that needed to see patients kind of every 30 minutes. um, and I even remember, that feeling of burnout. And so, yeah, I don't know, just continuing to advocate, for better reimbursement and really, trying to, again, match those exercises specifically to those patient impairments. So,
That's awesome. Yeah, I think I'm curious if I still think there is this prevalence of not physical therapists themselves not recognizing themselves as these primary care
right.
providers, and I still think that's kind of rampant in our profession,
Mm.
depending on what setting that person goes and practices in.
Yeah, I mean, that's a big thing and that I'm passionate about now, which is like, again, like we have to do a better job of advocating for our services. And I know I keep saying it, so the, the listeners are probably tired of hearing it. Um, it's all about providing good therapy, right? And so the only way that patients are ever going to buy in, because I do think, I hate to say it, but I do think that patients still tend to maybe go more towards the physician,
Hmm.
is if they see the value in physical therapy. And again, if we're just prescribing them with single plane exercises, straight leg raises, and that's what we're giving them for 6 weeks, 12 weeks, they're not going to see the value. It's not helping them. You're not progressing the patient to where they need to be to get to whatever, activity of daily living or sport that they need to perform in. And one of the things I always talk about is, and I try this and it becomes hard when you're seeing 16 to 20 patients a day, but for every single patient that walks in the door, you need to reverse engineer what that patient is going to need to do. So if they need to get to here, so if they need to be able to play basketball, then I need to dial all the way back to where I need to start. And at the end of my rehab, they better be
Basketball.
something
Yeah.
that they're doing better remotely relate to looking like basketball.
Right.
Right. And yeah. And so again, patients will never a lot of patients will describe like, I haven't found value in physical therapy. I hate to say it, but I think it's probably because we aren't providing them with good value physical therapy.
Absolutely.
So,
Absolutely. Totally agree. Well, that's all the time we have today. How can people connect with you more? You have some great courses on MedBridge that I highly recommend. How can people connect with you in other ways?
yeah, sure. So, I mean, my email is available. It's alexis.wright@tufts.edu. And yeah, if you enjoyed this podcast and you're interested, I've got some hip courses on MedBridge, some foot and ankle. I've got an SIJ course on there. Um, so yeah, so I encourage you to check those out. And just again, thank you for having me, and appreciate everyone's time. And for those who are listening, thank you.
Fantastic. Oh, that's so awesome. So glad you're on with us and that we could have this discussion because it's certainly interesting and fun. So, as far as me, if you want to connect with me, you can find more of what I'm up to at philplisky.com. And until next time, let's keep building the future of rehabilitation and performance together. Thank you for tuning into this episode of Rehab and Performance Lab by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Rehab and Performance Lab also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or a challenge that you would like to see addressed on this podcast, please let us know by leaving a comment on our Instagram post or by emailing podcast@medbridge.com. See you next time.